Hello, my name is James Neuberger. I'm a liver physician in Birmingham and chairman of the Medical Advisory Board of the PBC Foundation. What I'm going to talk about now is life after transplantation for PBC. It's an overview. There are an awful lot of detail that, because of time and so on, that I'm not going to discuss, but I hope it gives you a flavour of what to expect, the huge benefits from transplantation, as well as some of the consequences. Now, the first liver transplant successfully done in the world was done by Starzl in 1963, and the first successful liver transplant in the UK was done by Sir Roy Khan in 1968. In the early days, and I remember that well, transplantation was a highly risky procedure with a very high mortality. Now, because of a huge number of improvements, it's become virtually a routine procedure with very successful outcomes. And we're seeing people now who are alive 15, 20, 30, and even 40 years after transplantation. There are over 900 liver transplants done in the UK each year. Numbers vary, and of course, because of COVID, last year's numbers were down slightly. And we've got well over 7,000 liver transplant recipients alive in the UK at the present time. I'd finally make a point, there's still a shortage of organ donors, so do please encourage your family and your friends to make their wishes known that they do wish to become organ donors if they die in an appropriate way. And I would stress that by being an organ donor, it actually helps the family with the bereavement process. So not only does the organ donation help the recipients, but also the family. Moving on to the next slide. Now, it's important to say that life after transplantation is very good, but it's not normal. The quality of life is very good. We have people, for example, going up Mount Everest successfully, becoming summiters and coming down again, but it is not as good as normal healthy controls. Survival after transplant may also be reduced compared with healthy age and sex matched population, although actually this is not true for patients with PBC, since we think that their survival is similar to an age matched population. So PBC is a very good indication for transplantation. Now, one of the problems with transplants is that for the huge majority of patients, immunosuppression is needed and it's lifelong. A small proportion do become tolerant of their graft and can stop immunosuppression, but this has to be done very carefully because otherwise rejection and graft loss can occur. There are an increasing number of immunosuppressive drugs that are being used. They're classed into various groups, which you can see there. Most patients in the UK are managed on tacrolimus, Prograf, Advograf, Adaport, or it's got various names, often with either steroids such as prednisolone and a class of drugs called antimetabolites, which is azathioprine and mycophenolate. We're seeing a small but increasing number of new agents being evaluated. So there's a significant armamentarium of drugs, all with their own benefits and all with their own side effects. Now, the purpose of immunosuppression is to protect the graft from rejection, but immunosuppression itself has adverse consequences. There's a general impact, which is increased risk of some infections, increased risk of some cancers, and increased risk of heart disease. And then there are the drug-specific side effects, which may include bone marrow depression, renal impairment, high blood pressure, bone disease, diabetes, and particularly for sort of women of childbearing age, some of the drugs such as mycophenolate and sirolimus are teratogenic and therefore should be avoided in women who might or wish to become pregnant. So as always, you have to balance the risks and benefits of any treatment, and different agents have a different profile of side effects. Therefore, the choice and dose of immunosuppression must be carefully monitored and adjusted to individual needs. For example, with tacrolimus, I have some patients who are taking 1 milligram every third day, and others who are taking 15 milligrams a day. So huge variation, which has to be tailored to the individual. Some drugs, such as particularly tacrolimus and cyclosporin, are monitored by blood tests. It's important you don't stop immunosuppression without advice. It's important too that you are aware that some drugs and other factors such as grapefruit juice can affect drug levels. So some medications will increase the metabolism of drugs and so lead to rejection. Others will decrease the metabolism and so lead to toxicity. So when you're taking other medicines, always check with your GP, the pharmacist, or another health professional whether they interfere with the immunosuppression drugs. It's also important to remember that some drugs, such as tacrolimus, are manufactured by a number of different companies. Sometimes they are interchangeable, but not always. So again, check with your pharmacist or another healthcare professional to make sure that you're not switching brands inappropriately. Follow-up after transplant should be lifelong. Why do you need to be followed up? Well, you need to check on your well-being, any medical problems. You need to look for risk factors for complications, smoking, excess alcohol use, other factors. Weight gain is particularly a problem after transplant for a number of reasons. We need to check your blood pressure. We need to do blood tests, which include a full blood count, liver and kidney function, sugar, lipids, and so on, and check on your graft function, how well your liver's doing. And it's important to remember that, as with other liver tests or liver tests in other situations, the liver tests do not perfectly reflect the graft function. So you can have normal liver tests and inflammation in the liver, and conversely, you can have abnormal liver tests and the graft is perfect. Other factors you have to remember: some infections are more common after transplant, so treat early. If you have worries, call your doctor or your transplant unit. And if you're having antibiotics, particularly, be careful of drug interactions. For vaccinations, you should avoid live or attenuated vaccines, and the GP, pharmacist, or others should know which ones to avoid. I would stress that those vaccines, such as flu and COVID vaccines, which are safe for people with transplants, they may be slightly less effective than not in the non-immunosuppressed person, but the advice is very clear. You should certainly take the vaccines when offered. A recent study from the British Transplantation Society showed that of those transplant recipients who were fully vaccinated, few developed COVID and none died, whereas of those who declined vaccination, there was a much higher risk of COVID infection and a significant death. So please do take the vaccines when offered. It's important to remember that immunosuppression will increase the risk of some cancers. Not all cancers. Skin is a particular one, and therefore you should avoid unnecessary risk such as smoking or UV exposure, so wrap up carefully, use sunscreen in the sun. Not all cancers are increased, so for example, breast cancer is not increased after liver transplant, so you should have the same breast screening as you would normally have. There is no need to increase it. But you and your clinician should be aware that some cancers are increased and take any skin lump, any change seriously. As I say, the quality of life is normally very good. There are very few restrictions on activities. As I said earlier, we have patients who, led by Jacques Pirenne, have gone up Mount Everest, have gone skydiving, fishing underwater, and so on. Pregnancy is possible, and we now have many children born to mothers after liver transplantation. But there's one caution, as I mentioned: some drugs, such as mycophenolate and sirolimus are damaging to the fetus and so should be avoided in those who wish to become pregnant. After transplantation for PBC, the itching rapidly resolves. However, the lethargy or brain fog, or whatever you want to call it, however it affects you, improves only slightly. And we do see that this persists after transplantation. It's important to remember that other conditions associated with PBC, for example, thyroid disease, Sicker syndrome, and so on, do not improve after transplantation, and they may develop for the first time after transplantation. So always be aware that if you're feeling tired after transplant, it could be, for example, an underactive thyroid. Finally, recurrent PBC. Unlike PBC in the native liver, in the first liver, if you will, it can only be diagnosed with confidence by liver biopsy. The antimitochondrial antibodies persist after transplantation, whether or not you develop recurrence, and so aren't a useful guide. And the liver test may be normal in those with evidence of PBC recurrence, and there are many other causes of abnormal liver tests. So to be sure, the only way is to do a liver biopsy. With increasing time after transplant, the risk of developing recurrent PBC increases, so roughly 50 to 60% of people transplanted for PBC after 5 years have evidence of recurrent disease. But unlike other recurrent diseases, it's rarely a cause of graft loss and shouldn't be a major cause for concern. And recent evidence suggests that the impact of recurrent disease can be greatly reduced by the use of ursodeoxycholic acid from the time of transplant, and also by the use of cyclosporin rather than tacrolimus, although the latter is not always done because tacrolimus has other benefits as well. So in summary then, PBC is an excellent indication for transplantation, and outcomes are amongst the best for all indications. For the huge majority of patients, immunosuppression is required long-term, and the choice and dose of immunosuppression has to be monitored and adjusted. And this means, of course, that you need to be followed up, and followed up by people who are expert in that condition, looking after liver transplant patients. As people are 5, 10, 15 years out, blood tests every 3 or even 6 months are usually adequate, so it shouldn't impact on your work, social life, and so on. Immunosuppression is associated with risks. They can be mitigated in part by treatment of high blood pressure, treatment of diabetes, use of statins, and so on. But you have to be aware of these risks and act appropriately. PBC does recur in the majority of transplant recipients, but is usually not of significance from the clinical point of view. And we do believe that urso, from the time of transplant, reduces the impact of disease. So I hope that's given you a useful guide as to what to expect after transplantation. As I say, I've been involved with transplants for 40 years or more and seen the terrific improvements that have come. Clearly, the goal is to find a cure for PBC, so we no longer need to transplant patients. But for those who are either having intractable symptoms or end-stage disease, it remains a very good option that allows many people to lead a near normal life. Thank you for your attention.